Hello, you are listening to the RxConnect podcast. This podcast is brought to you by the pharmacy operations at the American Oncology Network. I am your host, Melody Chen, Vice President of Pharmacy Operations at the American Oncology Network. Today's episode is our final episode of 2025. As we close out the year, we wanted to take a moment to reflect on what 2025 looked like for community oncology, how care was delivered to patients, and what lessons we are carrying forward into 2026. At the American Oncology Network, we now support nearly 300 providers across more than 120 locations in 20 states, all focused on delivering high quality, patient centered cancer care close to home. At the end of the year, it looks like the right moment to pause, reflect, and look ahead. Today, I'm truly honored to welcome Dr. Divers to the podcast. Dr. Divers serves as the Chief Medical Officer of the American Oncology Network. He also serves as Officer at Large on the Executive Committee of COA, the Community Oncology Alliance. And on top of that, remains an actively practicing oncologist in Arkansas. What makes his perspective so valuable is that he brings together frontline patient care, network level leadership, and national advocacy all at the same time. Dr. Divers, thank you so much for joining me today.
Thank you, Melody, for having me. So I really appreciate the opportunity and look forward to the discussion today.
I'd love to start with a bit of a reflection. Looking back on 2025, what stood out most to you about this year in community oncology? Was there a particular moment or trend that really defined the year for you?
Yeah, I think it's a great question, Melody. And I don't think there was a singular or sentinel moment that really defined the trend for the year, but I think it was really a cumulative effect of multiple events. And so if you go back to early 2025 and you think about ASCO GI and ASCO GU, and we had lots of very specific precision medicine data which came out in certain patient subgroups, particularly those with MSI high tumors or those with certain actionable mutations, and we saw ctDNA data really become quite profoundly impactful. And then you saw that topic or that theme continue through the regular ASCO and then through ESMO, and then throughout the fall of this year. And so it was really, I think the theme was the significant escalation in the pace of innovation and the complexity associated with that at the point of care delivery. With respect to the provider and the patient. And so just, almost an exponential increase in significant advances that were really driven by precision medicine decisions or, in a fairly complex space. And so the complexity of oncology really, reached a point of inflection in late 2024 and throughout 2025, and we see that continuing. I think from the standpoint of, how that impacted community oncology, we saw rapid innovation, evolution, and adaptation to address that. And so whether that was, tarlatamab really taking place or taking a position in the second line setting in small cell and the need for practices to be able to adopt that to implementation of, data that came from Serena-6 and ctDNA testing and what's the cadence look like. So it was really a story of exponential innovation in the precision medicine space, and then how practices really pivoted and adopted to implement that.
Yeah. Absolutely. You bring a really unique perspective to lab reflections. And we know you wear several hats as a practicing oncologist, as the AON's chief medical officer, and as a national advocate. How did those roles shape how you experience 2025?
Yeah, I think you mentioned it earlier. It's really the grounding for me that occurs from those roles. I think a lot of times you end up leading much better from behind, and so I'm blessed to be surrounded by really amazingly insightful and bright people who help, and so I'm blessed with the opportunity to really learn so much, whether it be on a national stage with respect to interactions regarding policy and legislative changes to being blessed with an amazing leadership team throughout the network. And so I have the wonderful opportunity to continue to learn from all those folks. It does keep you grounded, and you really see how interconnected all that all of those um, experiences really change how you function from a practicing oncologist standpoint in the day-to-day business of seeing patients, but also from a network operations standpoint, what your strategic imperatives really might be for the year and how those are really impacted by what things look like on a macro level in the national landscape, whether it be, federal policy changes or payer changes. So I think, it is it can be a challenge to sort of keep all those balls in the air at one time, but I think it really does provide a unique perspective that allows us to um, truly see the entire gamut of the continuum of care that begins with policy and ends with administration of innovation at the patient level. And so, I think if you view any of those in a silo, you really don't get the full picture. And so it is a bit of a challenge, but I think it's also a real blessing to be able to have all those to impact the perspective.
Mhm.
Uh, and keep patients at the center, but also be a wonderful steward of the healthcare dollar, and drive innovation and implementation, throughout the network. So I think, it is a challenge, but it really almost is a necessary prerequisite to do the job well.
I believe me and my teams feel blessings and have such a great leader as you. And I want to stay on that clinical side for a moment. What do you think people most often misunderstand about the quality of care delivered in community oncology?
That's a really great question. It's something that we debated, in the Community Oncology Alliance board meetings for some time, whether the term community was a positive or a negative. I think there has been this, whether it's, correct or incorrect, there's certainly been this perception that perhaps, the outcomes and or quality in the community, though more convenient and perhaps more cost effective, may not equal the same, level of innovation and or expertise and or outcomes. And I think, that's a misconception that really exists, and I think it's a challenge for community oncologists to overcome. I think, we highlighted earlier that the exponential increase in complexity in the space really begs a question of how does community oncology really, um, you know, execute well in the care delivery model in such a complex space, in such a busy clinic, and I think my counter argument to that is, I think the more um, the busier you are, the harder you work, the better you get. And so, obviously, we need tools to help close the gap between, any innovations that exist or developed by life science partners, et cetera, but also, staying abreast of any and all updates and being sure that we implement those at the point of care. So, I think the big misunderstanding is that perhaps you know, a patient may need to sacrifice some level of outcomes for convenience to stay within the community. And I think, again, um, it's a bit of a misconception. The quality and outcomes within the community are quite good, and the level of innovation that's developed within the community is certainly on par. So I think that's something that the community practice is really will continue to lead with data to show that is in fact not the case.
Mhm. Yeah, absolutely. That misconception comes up very often, and it connects directly to patient care. Building on that, where do community oncology practices deliver the greatest value for patients compared with other care settings in your mind?
Yeah, I've thought about this before, and I thought about this partially in the setting of some data that should be coming out soon. But I think the behavioral economics of the community setting are actually quite a positive. And what I mean by that are, for the most part, these are patients that we may see at Walmart or in the grocery store or at a restaurant. And so, you know, there is significant accountability there. And so these are not patients that we're not going to run into again. And so, I mean, these are folks you're going to see in the community, at church, at meetings, what have you. And so I think that behavioral incentive to always remain the best advocate for that patient, I think, is really critical, and it drives engagement with the patients, and I think that's also what drives the innovation, because you want to be the absolute best advocate for them that you can, because there's a level of accountability in the community that may not extend to perhaps a tertiary referral center.
Yeah, absolutely. You're absolutely right. So now let's talk about scale and the leadership for a moment. From your perspective as a CMO, what investments or capabilities most directly improve the patient outcomes across a large community oncology network like AR?
Yeah, I think, you know, it's really people, process, and technology, and so I think, having a very set process for how new data is integrated within the network. And so, for example, the P&T committee structure that we have, we're blessed to have a wonderful pharmacy team that really presents, you know, most significant updates with respect to new FDA approvals and new indications. We have a robust discussion between a number of providers involved. Um, to make clinical decisions, and then being able to operationalize that, create awareness throughout the network to make sure that a rising tide really does lift all ships. And so I think, being in tune with the level of innovation that is rapidly expanding, but also being able to operationalize that throughout the network so all providers are aware. And, for example, if we as a P&T committee, based on data that's published, says, hey, this has become the de facto new standard. We make sure that, any and all clinics throughout the network are really executing at that level. I think to be able to do that effectively, you really have to commit resources to data. And so having sort of quote unquote your data house in order so that you can do continuous quality improvement, you can look back retrospectively and make sure that you're converting on those initiatives, whether it be precision medicine or testing or compliance with NCCN guidelines or, um, you know, landmark trials and changes in, the standard of care. So I think you have to really commit resources to, not only the intake, but the output of that education and also the identification of any gaps that may exist. And then, follow that from a process standpoint to make sure that you're measuring and closing those gaps as if and when they evolve.
Yeah. And talking about data, and we see there's a growing interest in real world data. Are we already seeing evidence, particularly in breast and lung cancer, which represent a large share of cancers treated in the community, that supports the idea that patients treated in the community practices are receiving care that's both safe and effective.
Yeah, I think absolutely, Melody. That's part of the continuation of that theme about commitment of resources, not only, on the data side, but also in the process and technology to implement novel therapies, whether it be radioligands or bispecifics, et cetera. So I think, being able as a network or a community practice to commit resources to make sure that patients have access to those novel therapies is critical. And then, as I said earlier, I think the data really drives that. So you have to really measure and monitor what those processes are. From a standpoint of outcomes, I think that it's super critical for community oncology to really track and document what the outcomes look like. As you alluded, breast cancer and lung cancer are, going to be some of the most common malignancies cared for in the community and in academia based on volumes. And I think, we would want to show that, the care administered is equivalent to that which is published within the landmark trials, whether that be, pathologic complete response rates or progression-free survivals, et cetera. And so I think ensuring that there is not a gap between published data and the actual real world experience. Historically, EHR level data is can be tricky to navigate, but I really believe in the technology that's now available with respect to using natural language processing and large language models. But you really have to commit significant resources to ensure that the data extraction outside of a manual extraction is really accurate. And so making sure your F1 scores in those AI models is really solid. And so I think we'll continue to see um, more and more data come out of the EHR over time, whereas perhaps previously this would have been taboo, as most studies were really focused on Medicare claims data,
Mhm.
and or payer claims data. So I think as we see how AI impacts our ability to deal with very large volumes of data and to do so in an accurate manner when done correctly, I think we'll see more and more specific outcomes that evolve out of the community oncology setting. And then, I think it'll be our job to sort of benchmark that, see where there are gaps and close the gap when possible.
Mhm. Yeah, absolutely. And as the therapies continue to evolve and the cancer treatments become more complex, what gives you confidence that the community oncology can continue to deliver the care safely?
Yeah, I think highlighting the safety concern is, as we look at novel innovative therapies, the do no harm part of the Hippocratic Oath, I think, is first and foremost there. But we also want to ensure access to these therapies. But,
Mhm.
truthfully, community oncology has always been at the forefront of innovation, whether it was, ensuring access to oral oncolytics or moving, infusional therapy out of the hospital to infusion rooms or, the addition of, immunotherapies and bispecific therapies and radioligands. So I think community is, again, because of the behavioral economics of the model is certainly engaged and has a vested interest in ensuring patient access to these therapies in what I would refer to as an optimal site of care, um, i.e., that offers the highest quality outcomes at the lowest cost, thereby being a good steward of the healthcare dollar. I think the complexity of these therapies, without question, creates a bit of a challenge, but I think this is where, you get back to the data and people and process and technology.
Mhm.
If you look at, the GDP for the country, it's continued to go up, but, the employment rates, um, haven't necessarily gone up, and it's because of improved efficiencies. A lot of that may be driven by some form of machine learning. And I think we'll see the same with respect to, the care delivery model and oncology practice. So you'll be able to deliver more with with the same amount of resources that you have. And I think that's what's really going to allow us to um, continue to ensure access to these complex therapies and complex decision support with the current level of staff that we have by implementing, technology to really level that playing field.
Mhm. Yeah. Yeah, I think it's also equally important have a great leadership and have a collaborating team work together. It's really make a difference. Um, as we close out 2025 and look ahead, looking toward 2026, what should patients, providers, and policymakers be paying closer attention to?
Yeah, I mean, that's a great question with a lot of complex answers. I think, from the patient standpoint, that, if we, we always try to view things through the lens of the patient, but, you also have to have, happy providers who aren't burned out, who really obtain fulfillment through the work. And so you want to be sure and look at their experience through the lens of the provider. And then again, as policymakers and payers look at the lens, of how are we being the best steward of this healthcare dollar here, right? It's a finite resource. And so I think, when we can, in fact, align all of those and keep the patient at the center and a happy provider and be a good steward of the healthcare dollar, I think, the sky's really the limit. And that's how we really, create a paradigm change in the, healthcare delivery model once we align all those incentives. I think, you know, from a patient standpoint, access to care is critical. There are a lot of policy fronts that are out there that may have positive and negative impacts. And so I think making sure your voice is heard, whether it be through Community Oncology Alliance or other advocacy, um, you know, groups, I think it's important to make sure that, again, we don't create a transformation in the healthcare ecosystem, which is solely driven by cost decisions. But I think for the most part, the U.S. has always done that, right? I mean, we're the largest consumer of expensive drugs, but we're also the largest consumer of generic drugs. And so I think, when there's opportunity to be a good steward, we do so. And when there's opportunity to lead with innovation and novel therapies that extend survival, we do so. And so I think you can continue to navigate that thread. But to your point, the lens may change somewhat, whether you're the patient or the provider or a payer or policymaker. And I think having the ability to sort of step out from your own echo chamber and look through that other lens every once in a while, and make sure we don't make decisions that have negative externalities that impact, one of those other stakeholders.
Mhm. Absolutely. Dr. Divers, this has been such a thoughtful and timely conversation. And thank you for sharing your perspective, not only as a leader, but as a practicing oncologist who remains deeply connected to patients and to the realities of community care. We truly appreciate your leadership at Aon, your advocacy through COA, and your commitment to advancing high quality cancer care in the community. Thank you.
Thank you so much for this time. I really always enjoy the opportunity to connect.
And thank you to our listeners for joining us for this final episode of 2025. As always, our goal on RS Connect is to connect people, insights, and practice so we can continue delivering better cancer care together. We look forward to continue these conversations in 2026. Until next time, thank you for listening.
The RxConnect podcast is produced by the pharmacy operations team here at American Oncology Network and music composed by the Synth Dude. Make sure to check out all our episodes of the podcast by liking and subscribing to our YouTube channel.